Come on in.
Hello, Addison.
Hi, nice to see you again.
Great to see you again.
All right.
It's been a few months since we last spoke.
Yep, it has. All well.
Yeah, so how's the Tegaderm treating you?
Oh, your product is doing fine in here. We've
Great.
had some nice success with it.
Great.
Yeah.
That's what we
Yeah.
love to hear. That's
Yeah.
awesome. So I think last time we spoke, you said you were going to New York over for New Year's. Is that right?
Yeah, back then, and now it's Super Bowl time. So
Right.
Here we go.
Man, it's an exciting one. I'll tell you that.
Yeah.
Golly. So I know that over email we talked that you had about a 20-minute window for this.
Yep.
Is that still accurate?
That's fine.
Okay, great. So I just want to, before we start, I'd love to give you my goal for this overall interview. I want to probe, get a bunch of questions out, get an overall view of kind of what y'all are struggling with right now.
Okay.
So that us as 3M, we can accurately attack y'all's issue and give y'all the most efficient solution. So I was wondering, is there anyone else that needs to be involved in this meeting in order to make a decision today?
No, we're good. I mean, I've got responsibility for those products that are associated with the infection rates and control of those processes here at the hospital. And
Great.
getting with you, we want to start looking at something where you've been involved with us and helping us on the Tegaderm, where you have a product, but you have to really get people using it and embracing it. We've got our stethoscopes that are single use and single patient types, but we're not getting traction with them.
Okay.
You know, we have them. We have 10,000 of each type sitting in our inventory here, and our rates of consumption are just falling from what we started. Now, obviously, we provide them for single use for oncology, NICU, neonatal, and also the burn unit. So those places are going to have these put out for just single use because you want to throw them away. You want to have nothing touching that patient.
Right.
Then the single patient ones are going to be in other wards where we're going to be a little bit less concerned about that, but still would like to use them as opposed to people, doctors specifically bring theirs around with them.
Right.
But since we're not seeing the use, we've got a problem, and I don't know where the problem is, but I suspect it's mostly with the doctors. I mean, the nurses, they'll follow the regimens that we say under the rules, and the nurses need the stethoscopes as well. But with the doctors, getting them to see a throwaway as a replacement for what they have is we are disconnected.
Right. So what are the doctor's main concerns with the single use right now?
Good question. So you can start there. I mean, I think it's assumption on my part. And maybe you have a better sense of it, but when you look at the quality and what they hear out of their own stethoscope and what they're either they never picked it up or they don't ever plan to pick it up, or they tried it and it's not good enough for comfort or acoustics. I don't know. I mean, I can only assume. I guess that's what I need help with.
Okay. Yeah. So what are your main? I guess I'll jump back a little bit. What are your main concerns right now with your isolation precaution standards, or what y'all are implementing right now? Because I know that you were coming to us with looking for a solution for that.
Well, it's like I said, we've decided where we put those out for use and what the policy should be with people attending to those patients. But that's what we can do on, say, the nursing side and the care side. But we're counting on the docs to observe those policies, and they're obviously not.
Right.
They're keeping their stethoscope with them,
right,
going from room to room, seeing these patients, hearing them. It goes on them, and the likelihood that we have a contaminant or a transmission of disease through that stethoscope, it's pretty high potentially. We just don't know it's high. But we really wanted to have the throwaways, either the single use or the patient ones, consumed and see its effect on the bottom line. Well, or on our rates, right?
Right.
Well, they're not being used at the rate we need to be. So we're not having an impact. Well, that's not a surprise because they're still
not being, So
we would expect that they'd be used at a higher clip.
Yeah. Would you say that might be a training thing with the doctors not using them? Or is it really just the single use y'all are using right now is just not effective enough for these doctors to pay attention to what the ramifications of that is.
You're on to what that's the problem I've got. I want to try and give that to you.
Right.
Because it's just something where, between product and use and training and, something's different or, new, don't know.
Right. So I was curious what y'all's hesitation has been so far with between switching from single use to single patient, maybe in your isolated units. Is that because you would rather have something that you throw away every time to contain the contaminants, or?
Right. I mean, in those units I mentioned, you really have a high risk because those patients are very vulnerable to anything that's going to be spread.
Okay.
In the other areas, I mean, ideally, if these worked as well as they could and they're affordable, it's, like a Band-Aid, you're not going to reuse it. It's just, we want to try and get these to be a used item that is thrown away, that we're not moving these around, that ideally it would be great if nobody had their stethoscope.
Right.
If they're going from patient to patient, because that can be, a concern.
Right.
And those are nice pieces of gear that they've
Yeah.
always had, and this is a different way, and we've got a lot of work to do.
Right. So what are the costs of dealing with these infection rates right now? If you have a ballpark number of that.
If we put an average on it or a number, there's a number of 12,000 that's out there.
Okay.
For trying to deal with a patient that has a problem, but also those costs are all borne by the hospital. If insurance doesn't pay for us infecting somebody here,
because it's something you could have prevented.
yes, they view it as prevented, so we own that.
Okay, so y'all are eating all of that cost.
And we also are dealing with, if it's found to be us, we're also dealing with all the if somebody dies, all of those things are bad news, and the 12,000 is a number, but I'm sure it can be way higher depending on the case.
Right.
So it's all and a lot of the wrong stuff.
Yeah. So I guess moving forward, I would ask, what are the implications of, say, a big spread in y'all's hospital? Because $12,000 per patient is incredibly stiff, especially if y'all are eating all those costs. So what does it look like for your hospital if, say, a major breakout were to happen?
Oh, yeah.
Speaks for itself a little bit.
Yeah,
right?
you can.
Yeah.
It's a really big number, but we have practices and processes today that we're trying to improve, and when we start to see a program not take, like this is not taken, that's what I'm trying to. I need to get after this, and if we bought them and nobody's going to use them, that's pointless.
Okay.
If we're not using them and we're not seeing improvements. Yeah.
Right. So and correct me if I'm wrong on anything. Here's kind of the issues that I've heard you state. You've got these single-use stethoscopes that it sounds like they're not great quality.
And both the patient type and the single use. Yeah.
Right. And specifically in your isolated care unit, you've got the single stethoscopes that are not necessarily great quality, but it sounds like they could work, but the doctors just won't use them because maybe issues with accurately diagnosing things, wasting their time, it's something like as trivial as uncomfortable earpieces. Yeah. Is that all correct? And then the cost of infection per person sounds really stiff. Is it correct to say that eating all of these costs is something y'all would love to get rid of or lower?
Yeah.
Okay, great. So, say you make no changes with your current situation. What are the implications for your hospital just moving forward? Say in a year or 2 years, you make no changes, you keep your current system. What does that look like?
Don't know. I just know that we've got a problem that we've got to start working on because we need to consistently move in the right direction right now. Although we have rates of these kinds of infections and problems that we foresee, this is a targeted area that we just want to see improvement on.
So what if I told you that I have a product that could possibly lower your infection rates. Is that something you would be interested in?
I called you because I think, you better, or we
Right.
don't have 20 minutes.
Well, perfect.
Yeah, okay.
I think this is a great time to move into showing you a little bit about our product.
Okay.
So you can take this. This is a pamphlet with a lot of the information involved. So a few of the issues that your doctors described, it sounds like we actually cover those almost perfectly. So the high quality acoustics, that is a huge aspect of this product. So doctors are going to be more likely to use this because they're going to be able to accurately diagnose what these patients are dealing with, as well as an increased technology with this. You can actually squeeze this and increase the pressure and hear different sounds within the lungs and heart. And yeah, feel free to try it and everything. We've taken care of the comfort and ease aspect of that with the improved earpieces, which I know is that can be a straw that breaks the camel's back with a lot of these doctors. The stethoscope doesn't work very well, and then the earpieces are bad, so they're just going to use their own. And then with this is our single patient option, and that covers the infection rates aspect. So I believe that with the single patient, you would actually decrease your infection rates because of the fact that this is an increased quality. It stays in the patient's room the whole time, and the doctors are going to in turn use it. And so I think that.
So just so I'm clear, a couple things. This is a single patient product,
Yes,
right?
yes.
As opposed to a single use.
Right.
Are you advocating that this should be used for ICU and NICU and the burn unit and oncology and places like that, and just throw it away?
No. So the great
So
thing
I still have two. I still have another one that I'd be buying.
So it would be say you have your patient right now. How many times does your typical isolated unit patient get visited?
Well, between nurses and doctors, you're going to be throwing away, 3 to 4 of these a day.
Okay, per patient.
Depending, because they're going to come in and listen to whatever it's going to be, depending on the patient. But the point is that they're going to be visited on rounds by nurses.
Yeah.
And and depending on what they're doing, then the doctor's going to see them. So you're going to throw away more than one a day or something like that for somebody who's in that situation.
And your current cost of your single patient is, I believe, $3.
$3.
Okay.
And then our single patient is $3.50.
Okay. So, I'd love to show you something real quick if I could. So, this is just a little 3M calculator that I made for this. So, how many? Let's go annually. How many patients do you think you have in your isolated care unit annually?
Yeah, see, to drive this, you're gonna need numbers that I don't have.
Okay, so let's ballpark it.
So just go ahead.
Say, and tell me if my number is just way too high. So say you have 4,500 patients in your isolated care unit annually.
Okay.
And you were saying that 3 to 4 times they're going to be checked up on with the single use, and then that's $3 down the drain every time. So let's go high and let's go 4. So that's going to bring you an annual savings of $36,000.
For how do you get savings?
So your single use cost is $3 each, and with an average of 4 exams per day on 4,500 patients annually.
I got to hold up there. I believe that in our units where they're going to need that, we're still going to have the policy of single use.
Okay.
Even if, because I don't, at this point, I'm not contending that we're going to change that.
Right.
And then we're going to have, to me, the biggest usage is still going to be on all the broader audience or broader population of our hospital that should be using a single patient. So it stays in the patient's room.
Okay.
That'll be the bulk of it. So we have a very small portion in those really high concern areas. I don't think we're going to be able to keep one in there for any concern with those patients.
Okay.
That's our rules, right?
Right.
So then we have this other group, and so, I guess what I'm saying is 50 cents more buys this one and it works really well. That may not be a problem,
Right.
right? I'm not too concerned about that.
Mm-hmm.
What I'm mainly concerned about, and the challenge we have here, is how do we get them using the blessed thing?
Right.
in the broadly in the hospital by the doctors.
Right.
Because if they have this around their neck and they go in that room and they use it, that's the problem.
Yeah.
And I'm here talking, I wanted to have you in here, like on the Tegaderm, you were able to make a transition by, making a transition. This is,
Right.
We haven't made a transition. We bought them, but now we're in a holding pattern.
Right. So I'll go back to one of the first things that I kind of touched on. I believe that this could be a training issue with your doctors, and correct me if I'm wrong on any of that.
That's fine.
So
I think you're onto something now, because I don't have an answer to that, but they're certainly not. They haven't embraced it.
Right. So what if I told you that 3M could bring in a staff and train these doctors adequately, and in turn decrease your infection rates and get the doctors following these guidelines that you all have implemented already?
If you can get them off of their stethoscope and onto these, when we start using, that would be good. Now, maybe, I don't know, maybe it's a problem with what we have, maybe it's a problem with, I don't know the answer.
Right.
But that's where I need the help.
Right.
That's where I need the help.
Okay. So, yeah, I think training. Okay.
So are you guys, in your capacity and what you do, able to engage the doctors to do things like this? Or are you
Yes.
more towards the nursing staff?
So we can bring in a team for the nurses. We can bring in a team for the actual doctors. 3M. The fantastic thing about 3M is that we cover almost all bases of pretty much anything you can think of. I mean, we're a Fortune 500 company with fantastic reputation. So I think that we would absolutely be able to bring in teams to train the nurses, train the doctors.
Well, I think if we're using them and we see the effect of using them, that's what I'm about.
Okay,
we
great.
bought them and we haven't seen any movement, and we're seeing less use. So we're not really getting there. So again, I'm repeating myself.
Right. So would you say that you would be interested in switching to this higher quality stethoscope? And we bring in a team to train the nurses and the doctors as well.
That's a good plan. I also have to deal with the reality that I've got a large quantity of these. We have 10,000 of each of the types sitting in our inventory. So we bought a lot already. So that's another kind of hurdle I'll have to get through.
Right, and with that cost, I believe that the infection rates will drop significantly with this product. And so you were just talking about how you have a lot of these products in holding right now. That's stagnant money. That's money that's not being put to use. So, but I believe that you'll be able to recoup that money pretty quickly with the transition to these, and our training staff coming in and then decreasing the infection rate, as well as I truly think you should switch your isolated care unit from a single use to a single patient. I think that makes a lot more sense money-wise, and I think the doctors will be more inclined to use that if it's already in there. They don't have to grab a new stethoscope every time they're going into a room. It's little hurdles that we're trying to overcome.
Right.
So does that?
No, I think that you're on. That's exactly what I'm looking for. To try and make something happen here.
Great.
And it is more expensive, but at the same time, we've run the numbers. That it's not drastically different, but
right. So what are your thoughts on after hearing kind of what I'm ready to present to you? What are your thoughts on moving forward with the 3M shipment of single patient stethoscopes?
Well, I think we've got to start somewhere with the doctors and trying to engage them in this issue.
Right.
Because if they're bought on it, they're smart people. They know that
Yeah.
they're risking the patient by having that.
Right.
But they obviously still pick it because of some things.
Mhm.
We got to get to that.
Gonna switch.